In this lecture, we're going to connect three deeply intertwined conditions: obesity, insulin resistance, and type 2 diabetes. These are not isolated disease states. They represent a progressive metabolic continuum. Obesity is not simply excess body weight. It's a state of altered endocrine signaling. As adipose tissue expands, particularly visceral adipose tissue, it begins to secrete inflammatory mediators that impair insulin signaling. Over time, this leads to insulin resistance, where tissues like skeletal muscle and liver no longer respond appropriately to insulin. The pancreas compensates by producing more insulin, but eventually this compensation fails, leading to hyperglycemia and type 2 diabetes. Today we'll explore the mechanistic bridge between adipose tissue dysfunction and metabolic disease. Before we dive into mechanisms, let's define how diabetes is diagnosed clinically. Diabetes mellitus is diagnosed using objective blood glucose measurements. The three primary laboratory markers are fasting plasma glucose, random plasma glucose, and hemoglobin A1C, which reflects long-term glycemic control over approximately 3 months. For a formal diagnosis, at least 2 abnormal measurements are typically required, unless the patient presents with classic hyperglycemic symptoms such as polyuria, polydipsia, and unexplained weight loss. Fasting plasma glucose is measured after at least 8 hours without caloric intake. A normal fasting glucose is below 100 milligrams per deciliter. Values between 100 and 125 milligrams per deciliter represent impaired fasting glucose, often referred to as pre-diabetes. A fasting glucose of 126 milligrams per deciliter or higher, confirmed on repeat testing, is diagnostic of diabetes. These thresholds reflect progressive impairment in insulin action and glucose regulation, the physiologic changes we're about to explore. Let's look at how blood glucose behaves over time following a meal. In a metabolically healthy individual, glucose rises after carbohydrate ingestion, stimulates insulin release, and is effectively cleared by skeletal muscle and liver. Within about 2 or 3 hours, the blood glucose returns close to baseline. In contrast, a person with diabetes will have a higher peak and, more importantly, a prolonged elevation of glucose. Insulin secretion may be impaired. Insulin resistance may be present, or both. As a result, tissues do not adequately take up glucose, and hepatic glucose production is not fully suppressed. Notice that the glucose levels remain elevated for many hours. It is this sustained hyperglycemia, not just the peak, that drives tissue damage over time. This chronic elevation is what HbA1c ultimately captures. In patients presenting with classic symptoms of hyperglycemia, such as polyuria, polydipsia, unexplained weight loss, or persistent fatigue, a random plasma glucose measurement can be diagnostic. A non-fasting glucose level of 200 milligrams per deciliter or higher is consistent with diabetes, particularly when symptoms are present. However, random glucose testing is not ideal for screening or excluding diabetes because glucose levels fluctuate throughout the day depending on food intake and stress and hormonal regulation. For confirmation, clinicians typically repeat testing using fasting plasma glucose, hemoglobin A1C, or an oral glucose tolerance test. The key point is that sustained elevation, not just a single spike, defines the disease. Hemoglobin A1C reflects chronic glycemic exposure over approximately 8 to 12 weeks, which corresponds to the lifespan of a red blood cell. The higher the average plasma glucose concentration, the greater the fraction of hemoglobin that becomes glycated, Unlike fasting glucose, HbA1c does not reflect a single moment in time. It reflects cumulative glucose exposure. Values below 5.7% are considered normal. A value of 6.5% or higher is diagnostic of diabetes. Intermediate values indicate increased risk and warrant further evaluation. HbA1c is particularly useful because it captures the chronic metabolic burden that ultimately drives complications. Random blood glucose provides a snapshot of circulating glucose at a single moment in time. However, because glucose levels fluctuate with diet, stress, and hormonal regulation, it does not fully capture chronic glycemic exposure. A more stable biomarker is glycated hemoglobin, or HbA1c. HbA1c forms through a non-enzymatic reaction between glucose and hemoglobin inside red blood cells. Specifically, glucose reacts with the N-terminal amino acid of the beta chain of hemoglobin to form a reversible shift base. This intermediate then undergoes an Amadori rearrangement to form a more stable catoamine adduct. That stable glycated product is HbA1c. Because red blood cells circulate for approximately 120 days, the fraction of hemoglobin that becomes glycated reflects the average plasma glucose concentration over the previous 2 to 3 months. Unlike glucose itself, HbA1c integrates glycemic exposure over time, making it a powerful and stable biomarker of chronic hyperglycemia. The oral glucose tolerance test, or OGTT, evaluates how effectively the body handles a standardized glucose load. It's particularly useful when fasting glucose or HbA1c results are borderline. After an overnight fast, the patient consumes 75 grams of glucose. Blood glucose is measured at baseline and again 2 hours later. In a metabolically healthy individual, insulin is rapidly secreted, peripheral tissues increase glucose uptake, and hepatic glucose production is suppressed. As a result, the 2-hour glucose value remains below 140 milligrams per deciliter. When the 2-hour value falls between 140 and 199 milligrams per deciliter, this is termed impaired glucose tolerance, a pre-diabetic state reflecting reduced insulin sensitivity. A 2-hour glucose value of 200 milligrams per deciliter or higher is diagnostic of diabetes. The OGTT therefore directly challenges the insulin response system. It reveals whether tissues can appropriately clear a glucose load. Diabetes fundamentally represents a failure of insulin-mediated glucose regulation, but the underlying cause differs between type 1 and type 2 diabetes. In type 1 diabetes, the pancreas fails to produce enough insulin due to the destruction of the pancreatic beta cells. This most commonly occurs through an autoimmune process in genetically predisposed individuals. Without insulin, glucose cannot effectively enter insulin-dependent tissues, and blood glucose rises. Treatment therefore requires lifelong insulin replacement. In type 2 diabetes, insulin is usually present, often in elevated amounts, but target tissues, such as muscle, adipose tissue, and liver, do not respond appropriately. This condition is termed insulin resistance. Early in insulin resistance, the pancreas compensates by producing more insulin. Hyperinsulinemia can temporarily maintain normal glucose levels. However, over time, beta cells become unable to sustain this increased demand. Glucose levels begin to rise, first in the postprandial state, or right after a big meal, and eventually in the fasting state as well. This progressive failure of compensation leads from insulin resistance to prediabetes and ultimately to type 2 diabetes. Type 2 diabetes does not arise from a single cause. It emerges from the interaction of genetic susceptibility and environmental exposure. At the core is insulin resistance. Genetic predisposition influences beta cell resilience, adipose tissue distribution, and inflammatory responsiveness. However, genetics alone are usually insufficient. Environmental factors, including excess caloric intake, a sedentary lifestyle, chronic stress, certain medications, and even intrauterine exposures, promote adipose tissue expansion, particularly visceral adiposity. As adipocytes enlarge, inflammatory signaling increases. Cytokines such as tumor necrosis factor alpha and interleukin 6 impair insulin receptor signaling, reducing cellular responsiveness to insulin. The result is a progressive shift towards systemic insulin resistance. Adipose tissue has traditionally been viewed as a passive energy storage depot. Its primary role is to store excess energy in the form of triglycerides and to release fatty acids during periods of metabolic demand. However, adipose tissue is not merely a storage organ. It's an active endocrine organ. Adipocytes secrete a wide array of signaling molecules known as adipokines. These include hormones such as leptin and apodonectin, as well as inflammatory mediators such as tumor necrosis factor alpha and interleukin 6. These adipokines regulate appetite, insulin sensitivity, inflammation, vascular function, and immune signaling. Importantly, the secretory profile of adipose tissue changes as adipocytes enlarge and the visceral fat expands. Obesity therefore shifts adipose tissue from a metabolically protective organ towards a pro-inflammatory endocrine organ. Adipocytes can be broadly classified into the white and the brown adipocytes, with beige adipocytes representing an inducible intermediate phenotype. White adipocytes are the most abundant and are specialized for energy storage. They contain a single large droplet of lipids and relatively few mitochondria. Importantly, white adipocytes function as endocrine cells, secreting adipokines such as the leptin, adiponectin, and inflammatory mediators, including tumor necrosis factor alpha and interleukin 6. Brown adipocytes, in contrast, contain multiple small lipid droplets and multiple mitochondria. They express uncoupling protein 1, or UCP1, which allows mitochondrial respiration to generate heat rather than ATP, a process known as non-shivering thermogenesis. While white adipose tissue becomes increasingly pro-inflammatory in obesity, brown adipose tissue is generally associated with improved metabolic flexibility and energy expenditure. This figure illustrates the progressive remodeling of adipose tissue as metabolic dysfunction develops. In lean adipose tissue, immune cells are primarily anti-inflammatory M2 macrophage. Adipocytes secrete protective adipokines, such as apodonectin, supporting insulin sensitivity and metabolic homeostasis. As adipocytes enlarge during weight gain, metabolic stress increases. We begin to see infiltration of pro-inflammatory immune cells, including CD8 positive T cells and M1 macrophage. The adipokine profile shifts towards inflammatory mediators such as TNF-α and IL-6 and resistin. In advanced obesity, adipocyte hypertrophy leads to hypoxia and cell death. Necrotic adipocytes become surrounded by macrophage, forming crown-like structures. At this stage, adipose tissue becomes a chronically inflamed endocrine organ. These inflammatory adipokines impair insulin signaling in liver, muscle, and adipose tissue itself, disrupting glucose homeostasis, increasing lipolysis, and altering fatty acid oxidation. This inflammatory remodeling is a central driver of insulin resistance and contributes to complications such as non-alcoholic fatty liver disease, atherosclerosis, and other cardiometabolic disorders. Before we move into the molecular signaling details, I want to ground us back in the actual tissue. This is white adipose tissue under the microscope. Each of these large, empty-looking spaces is a lipid-filled adipocyte. Notice how the nucleus is pushed back to the periphery. That's because the triglyceride droplet occupies most of the cell volume. These cells are not passive storage depots. They're metabolically active endocrine cells. White adipocytes secrete signaling molecules, including leptin, adiponectin, and the inflammatory cytokines such as tumor necrosis factor alpha. In lean tissue, this secretory profile supports insulin sensitivity and metabolic balance. But as adipocytes enlarge and become stressed, their secretory output shifts. And that shift at the molecular level is what we're about to unpack. Now that we've established that adipose tissue is an endocrine organ, let's look at one of its most important hormones, leptin. Leptin is produced primarily by white adipose tissue. Its circulating levels correlate with total fat mass, meaning the more triglycerides stored in the adipocytes, the higher leptin levels in the blood. Leptin crosses the blood-brain barrier and acts on the hypothalamus. It signals that energy stores are sufficient. The brain responds by reducing appetite, increasing energy expenditure, and decreasing food intake. That's why leptin is often referred to as the satiety hormone. In contrast, ghrelin is produced primarily by the stomach and is the hunger hormone. Ghrelin levels rise before meals and they peak just prior to eating and then fall after food intake. It functions as a meal initiation signal. So you can think of leptin and ghrelin as opposing forces regulating energy balance. Long-term energy storage signals from adipose tissue versus short-term hunger signals from the gastrointestinal tract. Under normal physiologic conditions, leptin acts on specific neuronal populations within the hypothalamus. It stimulates the productions of anorexigenic peptides, meaning appetite-suppressing signals, and it simultaneously suppresses the production of orexigenic peptides, which promote hunger. The combined effect is to reduce food intake and increase energy expenditure. In this way, leptin serves as a long-term energy status signal. When adipose tissue stores are sufficient, leptin tells the brain that energy reserves are adequate, helping to maintain balance. While most obesity is not caused by the lack of leptin, there are rare cases of congenital leptin deficiency. In these individuals, the brain does not receive the signal that energy stores are sufficient. As a result, the hypothalamus perceives a state of starvation, even when fat mass is high. This leads to severe hyperphagia, excessive food intake, and profound early onset obesity, as seen in this diagram. In these rare cases, treatment with recombinant leptin dramatically reduces appetite and body weight, as shown here. This demonstrates that leptin is biologically active and it's critical for energy homeostasis. In diet-induced obesity, meaning chronic caloric excess combined with sedentary behavior, adipocytes expand through hypertrophy. As adipocytes enlarge, oxygen diffusion becomes limited. Local hypoxia develops within the adipose tissue. This triggers chemokine release, recruitment of macrophage, and the development of chronic low-grade inflammation. This inflammatory remodeling contributes directly to insulin resistance. However, it's important to recognize that not all obesity is metabolically identical. Some individuals with increased fat mass maintain relatively preserved insulin sensitivity and show lower levels of inflammatory signaling. This distinction is strongly influenced by where the fat is stored. Visceral fat surrounds abdominal organs and drains into the portal circulation, meaning its inflammatory mediators go directly to the liver. Visceral adipose tissue is characterized by higher tumor necrosis factor alpha and interleukin 6 production, greater macrophage infiltration, lower adiponectin secretion, and it is strongly associated with insulin resistance, type 2 diabetes, and cardiovascular disease. Subcutaneous fat, located just under the skin, particularly in the hips, thighs, and peripheral abdomen, tends to retain greater insulin sensitivity. It secretes more adiponectin and fewer inflammatory cytokines. Functionally, it acts as a safer energy reservoir or a metabolic buffer. So subcutaneous fat primarily stores energy, but visceral fat disrupts metabolic regulation. So this raises an important clinical question. How do we measure obesity in a way that helps us assess disease risk? In clinical practice, obesity is most commonly assessed using body mass index or BMI. BMI is calculated as body weight divided by height squared, and it provides a quick and inexpensive way to categorize weight status at the population level. Based on BMI, individuals are classified as underweight, normal weight, overweight, obese, or extremely obese. These categories are useful epidemiologically. They correlate on average with increasing cardiometabolic risk across large populations. However, BMI has important limitations. It does not distinguish between fat mass and lean mass. It does not differentiate between subcutaneous and visceral fat, and it does not capture differences in fat distribution. This distribution matters because metabolic risk is driven more strongly by visceral fat accumulation and inflammatory signaling than by total body weight alone. Because BMI does not distinguish between fat distribution patterns, clinicians often use waist circumference as an additional metric. Waist circumference and waist to hip ratio better reflect central adiposity, particularly visceral fat accumulation. These measures correlate more strongly with insulin resistance, hepatic steatosis, and cardiovascular disease risk than BMI alone. This is because abdominal visceral fat drains into the portal circulation, exposing the liver directly to inflammatory cytokines and free fatty acids, which disrupt glucose and lipid metabolism. Advanced imaging techniques such as DEXA scans and CT imaging can directly quantify body composition and fat distribution. These modalities allow us to distinguish visceral fat from subcutaneous fat and assess regional adiposity with much greater precision than BMI or waist circumference alone. In research settings, these tools have been invaluable in linking visceral fat accumulation to insulin resistance, hepatic steatosis, and cardiovascular disease risk. However, these imaging techniques are expensive, involve radiation exposure in the case of CT, and are not routinely used for obesity screening in clinical practice. So obesity assessment is not simply about body mass, it's about fat distribution and metabolic consequences. This figure illustrates a paradox in obesity. As adiposity increases, circulating leptin levels rise substantially. However, the metabolic effects of leptin, including appetite suppression, improved insulin sensitivity, and lipid regulation, progressively decline. In other words, leptin levels go up, but leptin signaling effectively goes down. This disconnect is what we call leptin resistance. Leptin resistance does not arise from a single defect. It appears to result from multiple central and peripheral mechanisms. First, leptin transport across the blood-brain barrier may become impaired, limiting access to hypothalamic neurons. Second, leptin receptor expression can be reduced, or receptor signaling efficiency may decline. And third, and perhaps most importantly, intracellular signaling pathways downstream of the leptin receptor become disrupted. Although leptin is often described as a satiety hormone, it's actually a multi-system regulator that affects immune, endocrine, cardiovascular, reproductive, and cognitive functions. Leptin receptors are expressed in multiple brain regions beyond the hypothalamus, including the hippocampus. And in animal models, leptin enhances synaptic plasticity, learning, and memory. And in humans, low circulating leptin has been associated with cognitive changes seen in anorexia, depression, and possibly neurodegenerative conditions such as Alzheimer's disease. Leptin also functions as an immunomodulatory hormone. Hypoleptinemia has been associated with impaired immune response. Conversely, in obesity, elevated leptin levels stimulate pro-inflammatory immune pathways, contributing to chronic low-grade inflammation. Importantly, leptin resistance is selective. Satiety signaling may be impaired, while pro-inflammatory immune signaling remains active. Leptin is a permissive signal for reproductive functions. In women with hypothalamic amenorrhea due to low energy availability, leptin administration can restore menstruation and ovulation. Leptin also increases the heart rate and the blood pressure. Chronically elevated leptin levels have been linked to cardiac remodeling and left ventricular hypertrophy, which may increase long-term cardiovascular risk. Leptin normally acts as a brake on insulin secretion, a regulatory loop known as the adipose-insular axis. In leptin resistance, this inhibitory feedback fails, contributing to hyperinsulinemia. Over time, chronic beta cell overstimulation in the pancreas may promote beta cell dysfunction and progression towards type 2 diabetes. Thus, both hypoleptinemia and hyperleptinemia can produce pathology through deficiency in one case and selective resistance with persistent inflammatory and sympathetic activation in the other. So if leptin represents the energy sufficiency signal that becomes dysregulated in obesity, adiponectin represents the protective adipokine that declines as the adipose tissue becomes dysfunctional. Adiponectin is secreted by normal adipocytes and circulates in relatively high concentrations in lean, metabolically healthy individuals. Unlike leptin, adiponectin levels decrease as visceral adiposity increases. Adiponectin enhances insulin receptor signaling, improves glucose uptake, promotes fatty acid oxidation, and suppresses inflammatory signaling. Higher adiponectin levels are associated with reduced risk of type 2 diabetes, dyslipidemia, atherosclerosis, and cardiovascular disease. To understand how adiponectin exerts these protective effects, we need to examine its receptor signaling pathways, particularly its activation of the AMP kinase, or AMPK, and the peroxisome proliferator activated receptor alpha, or PPAR alpha. In many ways, the metabolic state of obesity reflects not only excessive leptin signaling, but insufficient adiponectin signaling. Adiponectin is one of the most important insulin sensitizing hormones produced in adipose tissues. Its levels are highest in lean individuals and decline as visceral adiposity increases. In the liver, on the left side, Adiponectin binds to its receptors and activates two major signaling pathways, the AMP kinase and the PPAR alpha. AMP kinase activation suppresses gluconeogenesis by reducing one of the key enzymes, such as PepCK, or phosphoenolpyruvate carboxykinase, and glucose 6-phosphatase. This decreases hepatic glucose output. In other words, adiponectin tells the liver, you don't need to make any more glucose. PPAR alpha activation increases beta oxidation of fatty acids, reduces triglyceride accumulation, and lowers hepatic lipid content. The net effect in the liver is reduced glucose production and increased fat oxidation for use as energy, and improved insulin sensitivity. In skeletal muscle, over here on the right, adiponectin also activates AMPK. This increases GLUT4 translocation to the plasma membrane, enhancing glucose uptake. AMPK and PPAR alpha signaling also increase fatty acid oxidation and reduced intramyocellular triglyceride accumulation. This improves metabolic flexibility, or the ability to switch between glucose and fat as a fuel to produce ATP. So adiponectin can be thought of as the metabolic guardian of insulin sensitivity. In lean physiology, it promotes efficient fuel utilization, fatty acid oxidation, and low inflammatory tone. In diet-induced obesity, that protection is progressively lost. This loss occurs through two primary mechanisms: reduced circulating adiponectin levels, known as hypoadiponectinemia, and impaired adiponectin receptor signaling, sometimes referred to as adiponectin resistance. As adiponectin signaling declines, insulin sensitivity decreases, fatty acid oxidation is reduced, and ectopic lipid accumulation increases, creating a metabolic environment that favors type 2 diabetes and cardiovascular disease. In lean physiology, adipose tissue is highly vascularized and metabolically flexible. Adipocytes maintain a balance between lipolysis and lipogenesis, and immune cells, particularly the M2 macrophages, support a homeostatic anti-inflammatory environment. Adequate vascularization ensures proper oxygen delivery and nutrient exchange, preserving insulin sensitivity and metabolic stability. In obesity, adipocytes enlarge, a process known as hypertrophy, but vascular expansion does not keep pace. This results in reduced capillary density and localized hypoxia. Hypoxia triggers stress signaling pathways and the recruitment of monocytes and polarization towards pro-inflammatory M1 macrophages. The adipose tissue microenvironment shifts from anti-inflammatory to pro-inflammatory. Among the pro-inflammatory cytokines produced in this environment, tumor necrosis factor alpha, interleukin 6, and interleukin 1 beta play a central role. Cytokine signaling interferes with insulin receptor signaling, promotes lipolysis, and amplifies inflammatory cascades within the adipose tissue. So among the pro-inflammatory cytokines produced in hypertrophic adipose tissue, tumor necrosis factor alpha, interleukin 6, and interleukin 1b play central roles. These cytokines activate stress kinase and inflammatory signaling cascades that converge on insulin receptor substrate 1, or IRS1, disrupting insulin receptor signaling. Cytokine signaling causes serine phosphorylation that disrupts IRS signaling, preventing effective activation of the PI3 kinase and AKT. As a result, GLUT4 translocation is impaired and glucose uptake is reduced. This is one of the central molecular mechanisms underlying inflammation-driven insulin resistance. In addition to impairing glucose uptake, cytokine signaling promotes lipolysis, increasing circulating free fatty acids, which further amplify inflammatory and stress kinase pathways. The result is a feed-forward loop that sustains adipose inflammation and drives systemic insulin resistance. So let's step back and integrate what we've built in this lecture. In obesity, adipose tissue undergoes structural and functional remodeling. Adipocytes become hypertrophic. Vascular supply becomes inadequate, leading to hypoxia, and immune cells, particularly macrophage, infiltrate the tissue, especially the M1 macrophages. This shift creates a chronic low-grade inflammatory environment characterized by increased production of pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin 6, and interleukin 1 beta. Now, while adipocytes can produce some of these cytokines, they're mostly being produced by the macrophage that get infiltrated into the tissue. These cytokines activate intracellular stress kinase pathways, including the JNK and IKK kinases, which converge on the insulin receptor substrate, IRS. This is the key signaling node in insulin receptor signaling. And the serine phosphorylation of the IRS protein disrupts its ability to properly activate the PI3 kinase and AKT, which impairs GLUT4 translocation and reduces glucose uptake. At the same time, inflammation promotes lipolysis, or the breakdown of lipids, increasing circulating free fatty acids, which further amplifies stress signaling in the feed-forward loop. The net result is systemic insulin resistance, a molecular bridge between obesity and type 2 diabetes. What we see, therefore, is not simply excess fat mass, but a reprogramming of adipose tissue from a metabolically protective organ into a pro-inflammatory endocrine organ that disrupts whole body metabolic homeostasis. Understanding these molecular mechanisms allows us to ask the next critical question: where can we intervene therapeutically to restore metabolic balance? And we'll stop there for this lecture.